What I'm wondering is what the Australian or the New Zealand people.
Well, he said that they don't have much of anything.
They deferred but didn't add a question.
Oh, they don't have anything. Okay.
Which is the simple way of doing it, is that you just defer but you don't ask. It's not obviously as complete.
I have some concerns as sort of about patients making self-diagnosis at the time. You know, have they ever had that? Because so many people think they've had chronic fatigue, and they just don't know what it is really, and they've been tired, so they think, well, that was chronic fatigue, and I would be concerned about losing a whole lot of donors, which could then be a problem for the blood bank system.
It would be a start if donors with a true diagnosis of a history of chronic fatigue could be excluded. And I mean that is a good start.
That to me would be the way to go. That we propose that and then ask them, you know, if they could develop some questions that they might include that would try and capture a greater percentage of the population. But I was sensing some urgency that, you know, get the message out there now.
Chris, let me add, though, that as much as I admire and agree with what Nancy would like to do in theory, in principle, we can't even get primary care providers to make the appropriate diagnosis, and these people are extensively trained. If that's the case, it's hard to imagine that patients, for exactly Art's gave a good example of that, are going to be able to do it. Get the 15% that are diagnosed, that do know they have it, get that blood out of the system until you find out whether it's a problem or not. If it's not, put it back. If it is, then you can extend it, and hopefully it becomes a nidus of interest. I mean, when Canada just recently decided to do the deferral, that got a lot more press about chronic fatigue syndrome than I've seen in a long time. So get that information out there. People start asking questions, then it gets that educational component. You know, I've been tired a lot lately. Could I have CFS? Enough people show up in enough primary care providers' offices. These people are going to demand CME credits to find out more, and you get a wonderful domino effect. So it has an added value past the blood supply, in my mind.
I just want to echo what Galen said. The public education function of doing something besides the safety virtues, which we think are enormous potentially, would really kind of involve publicity, education, media potentially would get interested in this, and we would have an opportunity to probably do a tremendous amount of education in this country, and it would probably, whatever happens in the U.S., would get international publicity.
So if we could make a if I can make a friendly amendment to Lenny's motion that we recommend to the Secretary that he ask the blood supply to indefinitely defer from giving blood people with a history of CFS.
And I accept that friendly amendment.
And are you going to put in there that we're going to ask them if they have a history of CFS?
With the inclusion of a question to that effect.
I would think one of the ways, maybe not to include a question, but to develop a strategy for capturing that patient population. Whatever the public group, the Red Cross or whatever strategy they would have to do that. It might be a question, it might be something else. But we certainly need a way to do that.
It's an interesting issue to bring it up because, you know, we often develop policy without good data about what's the best way of doing it. And we've just mentioned 3 or 4 really interesting questions that behavioral scientists would sort of be able to gather some information and make ultimately better recommendations about how to implement these types of discussions. So I just think that, you know, there's a lot of work that needs to be done. And, you know, we've just specified several really interesting topics that could be investigated.
Eleanor?
That all may be true, but I think the thing that you're bypassing is that this scientific working group is going to determine whether XMRV exists in the blood donor supply and what its prevalence is. And until we know that, and then they're going to be doing some epi studies with this data, so we'll have facts to work on. We don't even know what the extent of it is in our blood supply in the U.S. That's what these groups are doing now. And I know that Dr. Bell has written a very scathing thing about NIH is not supporting XMRV research and so on, but this is not true. In fact, we've just invited someone from the cancer, Stuart DeGrease from the Cancer Institute, to write up something special for the PA if they want to participate. But, you know, they're saying NIAID isn't paying attention. Well, who funded the Whitmore-Peterson research? NIAID, and it came through the existing chronic fatigue grant. So, I mean, our position at NIH, which we haven't publicized, is very much like the one that Jerry presented. We're waiting for answers. What does it exist in the blood supply? What is the prevalence? And then, is there going to be an association in these epidemiological studies? Before we pump vast amounts of money into research, but the potential for the research exists, and we are funding these things.
Sorry, Lenny.
Goes beyond kind of XMRV. I mean, really, I think what we're talking about is something we could have probably made a motion on this a year ago or 2 years ago, because the same issues would be evident, that we have a group of people who are very sick, who possibly should not be giving blood for a number of reasons, for their own health and possibly for safety issues.
They aren't. We don't know that. I mean, we don't know what the prevalence is in the blood supply, and that's what that's all about.
Let me just say, Dr. Hanna, first of all, I agree with 100% of what you just said. We don't know. But the same thing, I was a first-year medical student when two researchers from MD Anderson came down to Galveston to talk to us about gay bowel syndrome, and that it was a GI disease, and that these men were dying because of their GI disease, and what we subsequently learned was not the case. I am not equating chronic fatigue syndrome and HIV. I'm simply asking the question, is that I agree with you, pumping huge amounts of money into something until you know the direction you're going, particularly with the austerity of our research budgets.
But also, I mean, the research thing is one thing because that's going on, but do we want to create a scare before there's a need for one?
It's already out.
I mean, but I know I know
there.
exactly what you're talking about, because I didn't mention that before I came to the government. In fact, I had almost exactly the same career trajectory as Dr. Coe. I went from BU to Harvard to the government. Clinical, administrative, research. When I first took over, when Dr. Pinn asked me to take over the CFS portfolio for NIH, there was a lot of resistance to my doing it, because people said, what did I know about CFS? I couldn't possibly do a thing. And I said to those people, if I can do for CFS at NIH what I did for alcohol and drugs at Mass General, and they're ranked 7th in the country in treatment in those things, and I still maintain a presence there every time they get a new director. I go back and train them. So I understand exactly what you're talking about. And when HIV first came on the system, and nobody even knew about AIDS, we started picking it up as a brain disorder in our emergent 24-hour emergency clinic. And the first place we housed it for treatment was in our alcohol clinic.
Interesting.
So I'm very much aware of these things, but I really feel that we're going to get answers soon.
I don't think we have a problem with what they're doing in terms of the search for an answer with XMRV, and I don't think that's what the discussion is about now. I ask a direct question: what are the negatives to deferring CFS? Art asked the same question in a different way. I didn't hear any negatives. We didn't get a negative, did we, Art?